It is now a great pleasure to introduce somebody who's probably spent more years on smallpox than some of the people in this audience. Mike Lane was one of the early visitors to West Africa, domestic, and now he's very much involved in smallpox, bioterrorism, vaccination. And Mike's tradition is one of evidence-based decision-making, and he's going to share a little bit of that with you. Thank you, Mike.
Thanks, Dan. I want to look briefly with you at comparing the epidemiology of smallpox and measles as we found them in West and West Central Africa, because I think this is a critical issue in developing both the final strategy for smallpox eradication and current thinking about measles in third world countries. Smallpox and measles are superficially very similar. They both have no non-human hosts. They both have no subclinical carriers. They both result in permanent immunity if you acquire them. They're both spread by respiratory droplets to close personal contacts. They have approximately similar incubation periods. They both are sharply seasonal and have about the same seasonal pattern. They both have characteristic rashes, although smallpox is certainly much easier once you've seen it to diagnose than measles. And they have more or less similar pathophysiologies. The pathophysiology I won't go into, but was explained elegantly by the Fenner model of viral xanthims, worked out with ectromelia by Frank Fenner, who went on to get the Nobel Prize for this. The early World Health Organization statement about smallpox epidemiology, which drove us in the first year of West Africa, was that A, smallpox is highly infectious. B, smallpox was largely urban, and that's because it burned itself out very quickly in isolated rural areas. It couldn't sustain transmission, and so it had to have large population groups to sustain transmission. Smallpox was a disease of very young children because, since it was highly infectious, it quickly got to the young children, and they either died or became fully immune, so that older persons were either immune or had died. And because smallpox was highly infectious, smallpox eradication, WHO told us, would require effective vaccination of at least 80 and preferably 100% of the population, because smallpox, being highly infectious, could seek out little pockets of unvaccinated people and sustain transmission. Well, in the first year, and even before the first year, of the field program in West Africa, Bill Faggy, Rafe Henderson, and Pat Imperato, all of whom are here, and in fact several others in the field, showed that this view of the epidemiology of smallpox was in fact wrong. And their observations in West Africa were bolstered by EIS officer Tom Mack's analysis of smallpox importation outbreaks into Europe. And then when he left the EIS, he conducted the only population-based field study of smallpox ever done in West Pakistan. And I love to quote from Tom's paper on the European outbreaks. It is my judgment that under contemporary conditions, smallpox cannot be said to live up to its reputation. Far from being a quick-footed menace, it has appeared more as a plodding nuisance with more bark than bite. The unique epidemiologic features of smallpox were therefore central to the development of what came to be called the surveillance and containment strategy developed by Bill Faggy, which led to, number one, the much more rapid eradication of smallpox in West Africa than we had initially planned, and certainly then to carry on to the kind of work that Stan Foster and Bill Faggy and many others did in Asia. It's worthwhile, before looking at the smallpox epidemiology, to look at measles, because measles in West Africa, as Stan has already mentioned, was greatly feared and caused many, many more deaths than smallpox, despite the fact that it had a considerably lower case fatality rate, about 5 or 6%. Stan pointed out it was 20%, in fact, in kids about 18 months of age or so, versus about 12 to 14% case fatality rate in smallpox. Measles really did act very much like the World Health Organization view of smallpox. It was highly infectious, a disease of very young children, and largely, although by no means exclusively, urban. The very high case fatality rate of measles in West Africa, measles in the United States has a case fatality rate of about 1/10%. This resulted from the protein-calorie malnutrition that was basically rampant in sub-Saharan Africa, and the fact that measles, because it was so highly infectious, sought out infants just after they were weaned. And so you've got a child who was protein-calorie malnourished, was just leaving the breast, had additional lack of protein, and was lacking the maternal antibodies. As Stan has already pointed out, and Don Millar also mentioned, the very successful trial of the new Edmonton B measles vaccine in Upper Volta in 1964 was the major factor that, number one, USAID had interest in measles and sort of reluctantly smallpox, and certainly a major factor of the acceptance of our program by the West African nations themselves. Measles, certainly in West Africa, and I would argue generally, is much more infectious than smallpox, and that can be measured in several simple ways. Number one, already mentioned, much lower median age of attack, about 18 months for measles versus about 12 years for smallpox. Much higher secondary household attack rate. If a measles case was introduced into a compound in West Africa, in one incubation period, virtually all of the susceptibles would be wiped out, would basically get measles. Versus in smallpox, in the same situation, if you introduced a smallpox case into a compound, somewhere in the order of 33% to 88% of the susceptibles, 33% being during the seasonal low period, 88% during the seasonal high period, would become infected. Much larger populations were necessary to sustain transmission of measles. Two French demographers, Ray and Contrel, did work in Dakar, a city of a population of about 1 million, that showed that measles transmission could not be sustained in the city of Dakar without continuous importations into Dakar from other places. Whereas, as I've already mentioned, Rafe Henderson, Pat Imperato, and others, looking very early on in the first year of work, found outbreaks of smallpox where very small villages or isolated nomadic groups could sustain transmission for 5, 6, 7 generations of smallpox, with even populations as low as 200 or 300 populations. So clearly, this was a much less infectious disease. The unique epidemiology of smallpox, specifically this slow spread, and we very quickly documented that when the field workers investigated smallpox outbreaks, they found that transmission required prolonged face-to-face close contact with overtly ill patients. Very frequently, the patients could give a history of having spent the night in the bedside, in the same room, in the same hut of a patient with smallpox. This made contact tracing for smallpox quite easy, and contact tracing for measles was extremely difficult. In the weeks before the smallpox eradication program started in Nigeria, Bill Fege, who was at that time, as he was accepting the burden, if that's the right word, or maybe fun, he would say, of leading the smallpox program in eastern Nigeria, Bill detected a widespread and substantial outbreak in Agoja province in eastern Nigeria. At that time, we hadn't opened the pipeline to get vaccine, high-quality lyophilized vaccine there, so he didn't have much vaccine. So he instructed his friends and colleagues to vaccinate the immediate household contacts of cases in this widespread outbreak. To his surprise and delight, the outbreak simply was eliminated quickly. And in retrospect, C.W. Dixon, who had written the most authoritative textbook on smallpox, been a medical officer in the British Colonial Medical Service, he'd done a similar job in Tripolitania, now Libya, right after World War II, when he had heat-unstable, non-lyophilized vaccine, no refrigeration, and there was a widespread outbreak of smallpox, and he had his workers vaccinate just the people in the same tent of patients with smallpox, and smallpox quickly disappeared. In sum, therefore, we learned very quickly that smallpox spreads slowly, its contacts can usually readily be traced, outbreaks can be controlled by vaccination of immediate contacts of cases. This was very important in the eradication of smallpox and the change from mass vaccination to surveillance and containment. Unfortunately, measles is much more contagious, and Jean Roy will be talking about the modern approaches to measles control and hopefully elimination shortly after the break. And we'll hold questions, I think, until after that.